Hello, today we're going to talk about common pediatric skills variations that you'll see when working with children. These are going to be skills that that differ slightly and vary from how you would care for a child or assess a child with this situation versus an adult, or common high volume skills that you may see in the pediatric inpatient hospital setting. First off, looking at tracheostomy tubes, we're going to look at how to assess a patient with a trach tube, indications for suctioning a patient with a tracheostomy, and other safety considerations that are important. General indications for use with tracheostomy tubes would be patients with some type of congenital malformation, such as tracheomalacia, things like that would cause them to have a congenitally floppy airway. Patients with long-term ventilation requirements, like a preterm ex-NICU baby. A lot of them have chronic lung disease. They frequently have bronchopulmonary dysplasia, or BPD, and respiratory distress syndrome, also known as RDS. And what this means is it makes it very hard for them to breathe. Commonly, for example, like if you have the first time you go to blow up a balloon, you know how hard it is to push that air in and the balloon doesn't quite want to stretch out. For patients with BPD and RDS, it's like that every time they go to breathe. It's very hard to open up their lungs, and it causes a lot of resistance and a lot of difficulty breathing. And so frequently they may require trachs to make that easier for them. Other conditions would be acquired airway obstructions, such as epiglottitis, which is an infectious disease process y'all will talk about more in respiratory, caused by the Haemophilus influenza or Hib virus. Or say you had someone who was choking and they had an obstruction higher in their airway, so you weren't able to thread an endotracheal tube, either due to some type of something they swallowed, obstruction, or because of swelling, and so they would have to go lower and insert a tracheostomy tube. So the first thing you want to do when working with your patient is you always want to do an assessment. That's the biggest thing that differentiates, an RN, is their ability to assess, reassess, and intervene before their patient deteriorates, and to recognize that early on to prevent further deterioration. So you always want to walk in your room and look at your patient and do a whole doorway assessment and survey. What does the situation look like? What does your patient look like? Look at their respiratory rate. Do they appear to be breathing fast or slow? Does it look like it's within normal range if they're on a monitor? What's their color? Are they pink? Are they pale? Are they dusky gray? Are they diaphoretic and sweating? If they are on a monitor and have a pulse oximeter, what do their O2 saturations look like? Where is the pulse ox? Is it secure? So are you getting an accurate reading? Remember, if you're working with an infant or a small child, if it is placed more peripherally and you don't think you're getting an accurate reading, or their perfusion is poor and they're cold in the extremities, you may need to move that pulse oximeter more centrally to get an accurate reading. Do you see visible secretions from their nose, their mouth, or their trach? Are the secretions clear? Are they yellow? Are they green? Are they thick or thin? What is the consistency of those secretions? Is it obstructing that trach or the airway and causing further distress? What's the general work of breathing? Is it unlabored? Or does it appear to be labored? If they have retractions or the pulling in between your ribs or your above or below your sternum, note where those retractions are. Are they between the ribs? So are they intercostal? Are they below the ribs? And subcostal? Are they below the sternum, substernum? Things like that. Are they using any accessory muscles to breathe? Do they appear to be breathing abdominally with much force? With infants and things like that, they're traditionally abdominal breathers. As they fuss and cry and go into respiratory distress and take in a lot of air, all that does is it builds up in their stomach, causes further pressure on their diaphragm, and can cause further respiratory distress. So you want to check and see that they're not using other accessory muscles that indicate they're having trouble breathing. When you're looking for their general respiratory rate and work of breathing pattern, with infants and small children, they generally are abdominal breathers. And about age 7 or so, they switch to a more thoracic breathing pattern, especially for girls. Sometimes boys use a combination of abdominal and thoracic breathing even after age 7. So just be aware you want to look at the whole chest when you're trying to assess that. As far as breath sounds, are you hearing any audible breath sounds? As far as, are they sound coarse? Do you hear wheezing? Do you hear grunting? What's going on with that? Does it sound coarse and wet? When you put your stethoscope onto their chest and auscultate, are the breath sounds clear? Do you hear crackles, rhonchi, things like that? What's going on? When you're looking at their overall appearance and activity or their mood, is the patient calm? Are they sleeping comfortably? Do they appear to be restless and fussy? Restlessness in children is one of the earliest signs of respiratory distress. Are they refusing to eat or having trouble keeping food down? Are they on oxygen, or are there any other respiratory adjuncts being used? So if they're on room air, you would want to note that and make sure that they're not in any distress. If they have a ventilator, and many patients who are on a chronic trach, especially at night, may use a ventilator at night. They may use it 24 hours a day. It just depends. Do they have something stuck at the end of the trach, like a speech valve? Do they have a heat moisture exchange, or an HME, which is a humidifying filter that can pop on the end for patients who are on room air, but they have an HME to help humidify the air that they're breathing and decrease resistance and irritation to the airway. If they have a trach collar, they may also have humidified or blow by oxygen as well. What's the appearance of the actual stoma site where the trach is inserted look like? Your stoma sites, you want them to be nice and pink with no drainage, no excoriation, things like that. If they are, you want to note and make sure that the trach tube is not stuck to the stoma site. That if it is drainage or bleeding, you want to note the quantity and characteristics of that. After assessing the actual patient and the stoma site around the trach tube, you want to assess the tracheostomy tube itself. What does it look like? Does the trach appear to be intact? Do you see any visible cracks or some type of malfunction with the trach tube? What type of tube is it? Is it an adult tube, a pediatric, or an infant tube? Notice on the trach whether it says it's a Shiley or a Bavona trach. You should be getting this information and report as well, but you always want to assess your patient and make sure the information that you got and the information that is in the chart is correct. What is the size of the tube? Note if the tube is cuffed or uncuffed. If it is a cuffed tube, you want to note if it is actually inflated or not. And does the tube appear to be intact and actually in place, as we talked about, or does it appear to be dislodged, and does the patient appear to be in distress? Okay. We actually had a patient that we cared for in the hospital several semesters ago. It was a teenager that had a chronic trach due to sleep apnea and obesity, and they had some issues with their durable medical equipment and their home medical supplies, and what happened was they did not have extra trachs at home. And so the patient had had the same trach in for over a year. The trach had not been replaced as needed, and the trach had broken. And so the skin and the area in the stoma around the trach site had grown up and actually was stuck to the trach. So when they came into the hospital, they were not able to just replace and trade the broken trach out. They actually had to take the patient to surgery, put her under anesthesia, remove the trach surgically, and then replace a new trach. And so that's just something you always want to, make sure that there are not any issues, and always follow up with your patients to make sure they have the equipment and supplies they need. So going back to what type of tracheostomy tube do we have? The first you're going to see on the left is an example of a pediatric Shiley trach. These trachs are ones you generally have probably seen used in adults as well. They're hard plastic. They are more widely used than the Bavona trachs, and they're also cheaper overall. With this actual pediatric Shiley trach, you are seeing the nice Velcro straps attached to it, which makes it very easy with children to remove the edge, clean under, and keep their neck and their skin integrity intact and really clean, and then replace them as well. Other ties you may see used are those shoestring type string ties. If you look at the red circle with the arrow pointing to it, that's where you're going to check and see the actual size of the tracheostomy tube. This is a pediatric Shiley trach. It is a 5.5 or a 5.5 size, and you'll see between Shiley and the 5.5 ped, it says no cuff, so it is an uncuffed trach. To the right, you see a pediatric Bavona trach. These are generally made of silicone. They're a little more flexible than the Shiley trachs. You'll see these used a lot with patients with neuromuscular conditions that would cause them for their head kind of to fall forward and not be able to support their neck as well, and some preterm infants, and what they would cause kind of no neck, so that these patients would lean forward, their chin would fall forward, and if they had had a Shiley trach, they would actually occlude the end of the trach with the way they're bunched down. And the Bavona trach, if you notice, it sticks out further. And so there doesn't cause that occlusion that would happen with a Shiley trach. But you may see both in the clinical setting. So one of the most important things when you're doing your bedside safety checks every shift that you want to do is that if you have a patient with a tracheostomy tube, you must check that there are quite a few things present at the bedside. So what do you always want to have at the bedside of a patient with a tracheostomy? And there are generally 4 things that we're looking for. First off, you're looking to make sure that you have suction, that there's the actual setup that is hooked into the wall, that the suction turns on and off, and that you have the supplies, that you have a canister, that you have the tubing, and that you have the actual Yonker catheter, pediatric Yonker, or neosucker, which is a very thin, flexible catheter that you may see used with infants and children in the pediatric hospital setting. You should be checking for this with every patient, but it's even more important with those with trachs and those with respiratory conditions. The next thing you want to look at is, do you have oxygen and the setup with the ambu bag? So do you have your oxygen tubing? Is it hooked up into the wall? Do you have an ambu bag, and is it the appropriate size for your patient? And then the last 2 things, you want to make sure that you have extra tracheostomy tubes, those spare tubes. You want to have one spare tube that is the same size as the patient and one that is a half size smaller. So if you have a patient with a pediatric Shiley trach that is a size 4.0 or a size 4, you want to make sure that you have an extra spare trach that is a size 4 PD Shiley and an extra spare trach that is a size 3.5 or 3.5 PD Shiley. So if you look at the top, you will see a 4.0 neonatal Shiley trach on the left, and you'll see a 3.5 PD Shiley trach on the right. So the spare trach that we would want to have that was a half size smaller would be the one on the right. Now what you always want to do is, if you walk, you always want to check and make sure that these are at the bedside. If they are in a box, you want to open the box and make sure the trachs are actually in the box. Many facilities will tape those to the bedside and say they changed out a trach and they popped it out of the box and left the box taped to the bedside. You don't want to wait until you get into an emergent situation and need a spare trach only to find that the box is empty. So you always want to make sure that you've checked and made sure your spares are in the box. Some facilities now will actually put them in a clear bag at the end of the bed with the supplies, extra supplies and things like that, so you can actually visualize the trach without and keep it clean at the same time. Families should always have a go bag, what they call a go bag, with them if they have a child with a chronic trach, and in it what they would have would be their extra trachs. Other things you may want to have at the bedside is lubricant. The main reason we would want to have some type of Surgilube or Sterilube at the bedside to use is that you never want to put something that's dry in something that's wet. For example, it's going to cause friction, it's going to cause further irritation. So we're not going to stick a dry trach in the oral airway that's always supposed to be moist, especially if it's already irritated. So you want to make that be able to go in smooth and not cause further airway trauma. You want to have extra trach ties. And then if you've got shoelace ties, you want to make sure that you have scissors available in case those needed to be cut in an emergency. Indications for suctioning a tracheostomy tube. If you have audible or visible secretions, if you have visible secretions that are coming out of the end of the trach, you can go ahead and use the suction catheter, just a clean suction catheter, to get those that are coming right out of the end. If you are actually going to have to insert a catheter down into the trach tube, that needs to be using sterile technique. Do they have an increased respiratory rate? Are they grunting or having noisy breathing, or are you seeing other signs of respiratory distress? So in suctioning a trach tube, you want to use the pre-measured technique. You don't want to go any further than 1/4 inch longer than the end of the trach tube. Now, you can use a new trach and measure that for yourself. A lot of times on the trach box, it will tell you in the instructions on how far you can measure. And then many of our patients will have a sign at the bedside, for example, that might say, "Hi, my name's John, and I have a 5.5 uncuffed PD Shiley trach, and you will suction me no further than XX centimeters." Or if there's colors on your suction catheter, no further than the red line. And that kind of gives you, a better idea, and that way everyone knows the safest technique and length to use so they don't go too far and further irritate the airway. You want to use the largest catheter that fits inside the trach tube, and what that's going to do, that and the rotating motion is going to help clear all the surfaces of any secretions and help clear that out and make it easier to breathe. A quick initial pass should be made to clear any secretions, and then with each additional pass, it should be 5 seconds or less. It's good to use a suction, an intermittent suction, going both while inserting and removing the catheter is recommended. And then we talked about that rotation as well. The use of saline is not recommended. It can actually cause further irritation and trauma and cause aspiration and choking and actually further issues. The best way to make sure that your patient's secretions stay thin and easy to suction out is to make sure that they are well hydrated overall, so that they're either taking in enough fluids, enterally, parenterally, the best way to do it. And then you can also use a closed suctioning system to help reduce the risk of contamination and infection. And you will see those commonly on patients who may have a trach tube or an endotracheal tube. That's on a ventilator as well. They will have a closed suction inline suction catheter system. Now we're going to talk about enteral tubes. Assessing enteral tubes, verifying placement of those tubes, and then administration of medication and feedings through enteral tubes. Two types of tubes, enteral tubes, that you may see in patients in the inpatient pediatric setting are the pediatric Salem sump tube, which is on the right. Those are traditionally what you've probably seen with adult patients. They're used to suction and to vent if they have abdominal distension. And then a lot of times what you'll see in pediatrics is on the left, which is, there's different brands, but this one's actually called a core pack, but it's a nasogastric tube. At the bottom, it can either be right here at the end of this tip, it can either have a weight in it, or it can be weighted or non-weighted. And those are traditionally used for feeding or medications. So you always want to know what type of tube that your patient has and what it's being used for. When verifying enteral tube placement, you always want to make sure that you're wearing gloves when working with any type of enteral tube, nasogastric, gastrostomy, jejunostomy, any type of things, because you may come in contact with gastric secretions. Again, physical assessment of your patient is the most essential component in determining whether your tube is in place. So you always want to look at your patient. Are they having coughing, cyanosis? Are they short of breath? Are they having other signs of respiratory distress? Behavior-wise, do they look really uncomfortable? Are they complaining that it feels bad? If it's a small child, are they restless? Are they irritable? Are they able to vocalize? If so, do you hear, are they hoarse? With an infant, you may see a weak cry, or they may be unable to cry. What does their color look like? Are they pink? Do they have pallor, or are they mottled? So you're going to look at your patient first, and then you're going to actually look at the site itself. So when you're looking at the insertion site and assessing it, you're going to look at for internal skin breakdown, and then you're also going to look at the integrity of the internal nair tissue. So with this child, you actually see right here that you're going to look and assess where that tube is placed at the nair, and this child has it at 26 centimeters at the left nair, and that's how it should be listed in the medical record. You may need to rotate from one nair to the other to decrease the risk. If you're seeing a lot of tissue irritation, you may want to move it before you have impaired skin integrity and skin breakdown internally or externally. And with kids, we do not, because they still have soft tissue in a lot of these areas and their cartilage in their nose is not fully developed. So you can cause permanent skin impairment, skin integrity breakdown, and deformity if you secure that tube to their nose. So you always want to make sure that you have it pulled to the side and secured to their cheek. You can put Duoderm underneath it to help keep skin integrity intact, and then place like a transparent or occlusive dressing on top of the tube. So then if you need to change out the dressing, you can still do that and keep the Duoderm intact on the patient's cheek, protecting their skin. Now, the one thing children are is active, even if they're sick and in the hospital. And so anytime you have any type of line, tube, or drain, they will try to pull it out. And they can get really creative because they think it's really funny sometimes. And if they want your attention, especially, NICU babies that have had constant attention and things like that, they will hold their breath sometimes till it pops, like the trach cap off the end of their trach, so that it beeps at you. They'll pull their lines out, they'll bite through them if it's up near their mouth, things like that. So one of the things at high risk is if they do have a nasogastric tube. And so one of the things that you can do is you can actually take the end of that tube and wrap it around the back of their ear and kind of run it down the side and stick it underneath a onesie or their shirt. But they also may use soft splints, limb splints on their arms as well to keep them from pulling at that tube. And those are known as soft limb restraints. They're considered like a medical intervention, and they are not considered to be a behavioral restraint when working with children. So after we've assessed our patient and we've assessed the external appearance of the enteral tube, we want to turn around and look at how else are we going to verify placement, because it can look just fine outside and it could still be down in their lungs versus in their stomach, or it could be pulled back further than it needs to. So we always want to verify placement upon insertion, before intermittent feedings and med administration, routinely during continuous feeds, and whenever there are concerns regarding placement. The chest X-ray is considered to be a gold standard when assessing placement. It should be done always to confirm initial placement, and then to verify placement if you are unable to do so effectively by any other methods. Different agencies have different protocols following this, so before you perform any skills in the clinical setting, you should always look and see what the hospital's policy is and make sure that you're following their policy. For example, with kids or anyone, are we going to perform a daily chest X-ray just to confirm nasogastric tube or enteral tube placement? Are we going to radiate them every day if they're not having that done? Obviously, if the kid's in the intensive care unit and they're getting a daily chest X-ray to look at their lungs and things like that, it's just a bonus that we can see if their enteral tube is placed in the correct placement. But routinely, we are not going to do a daily chest X-ray just to obtain placement. So there's several other methods that we can use to check and see if your enteral tube's in place. I will have you note that we do not inject air and auscultate to verify placement of enteral tubes. This is not recognized as an acceptable method. There are some facilities that may still do it, but it is not validated or recognized, and it is actually, because it can actually be placed further up in their airway or in their lungs, and you will still be able to hear it over their abdomen due to the size of a child and when you're looking at their overall musculoskeletal development. So other secondary methods that you can use to assess placement: you can aspirate gastric contents and look for color with a enteral tube that is a gastrostomy tube. It should be grassy green, or it may be clear and colorless, and if they have residual formula or have continuous feeds, it may be cloudy, white, or formula colored. With a jejunostomy tube, which is post-pyloric and placed further down in the intestine, we don't typically aspirate for contents or pH, but if you do, you may find a golden yellow, yellow-brown, or like a greenish-brown in color, and that pH is generally going to be greater than 6. You can aspirate gastric contents for pH testing, and down there at the bottom right you will see pH strips, and those should be at the bedside of a patient that has a nasogastric tube. And with that, what you're looking for, if with intermittent feeds you want a pH of less than 5. If it's greater than 5, you want to wait 30 to 60 minutes and then retest. If they have continuous feeds, you want the pH to be less than 6. So most facilities have in their policy as you can check by x-ray, you can check by assessing where the tube is placed, and you can check by gastric contents for color and or pH. So you really want to look at their policy and see what it is and which are acceptable methods for that facility. The other method that you should always be doing when you're assessing your patient as well is where is the tube marking placed externally. So as we looked before, with our child right here, this is at 26 centimeters at the left nair. You always want to check placement at the nair and compare it to the chart. If the tube is not numbered, for example, our child on the left, it's either turned where you can't read the number very well and taped and things like that, or it is not numbered, you want to mark the tube with a black marker at the nair, and then you want to be able to verify it at the mark with each assessment. So what are we going to do if we're unable to find the measurement in the chart of where the nasogastric tube should be placed? Well, first off, we're going to look at the chart, look at the nurse's notes and things like that. If we don't see it there, you can go back and look through the chart and find out when it was last verified via x-ray placement. If it's been done within the last 24 hours, you may be able to use that. And then we try our other methods to verify. At that point, if we have confirmed within all shadow of a doubt that it is in place, we are then going to document that it is in place and document the reading at that point of where it's located at the nair. Gastrostomy tubes. So we have our nasally inserted enteral tubes, and then we have other surgically placed tubes, and that would be your gastrostomy tubes. And so a picture here is this is a low profile, close to the skin, surgically inserted. This is an actual, on the left side, is what's called a Mickey gastrostomy tube or button. It is surgically placed percutaneously, inserted directly into the stomach, and it has one port. To the right, you'll see the Mickey gastrostomy jejunostomy tube, and it's inserted directly into the stomach and the small bowel with 2 ports. And one important thing to note with this one is that which port the meds or feeds should be administered through. Sometimes they want meds inserted into the stomach, but they want feeds into the jejunum and things like that. So you always want to notice if there's a specific preference or order for where those should be placed. Generally, we see gastrostomy tubes used for when you have something for long-term enteral feeds or when esophageal atresia or stricture is present, so they wouldn't be able to place a nasally inserted enteral tube. And then with jejunostomy tubes, they are long-term internal feeding tubes as well, indicated when gastric feeding's not tolerated. When we're assessing these tubes as well, because they are surgically placed, we do not you can draw back and check the residual on them, but you're more looking and assessing these sites for whether they're in place and whether there's any complications with those. So first off on this one, if you look at the red circle, you will see the size. So this is actually an 18 French Mickey button. And then you'll see the Mickey button with the extension tubing. The extension tubing and package comes as a package set. They are not disposable. So you always want to keep that extension tubing. If you don't have it, you're not going to be able to administer meds or feeds into the patient's button. The nice thing about the gastrostomy buttons or enteral feeding buttons that are placed this way is that it can be hidden under the kid's clothes. They don't pull at them as much. If it's a kid with cystic fibrosis or something like that, that's going to have problems with feeds and needing to grow, and so they're going to have extra feeds. What it's going to help with is they can go to school and have this button and no one's going to know it's there. And so it's not going to cause an issue with body image or things like that. The biggest thing when you're looking at this is you're looking at their stoma site overall. The skin should look normal around it. The stoma site itself should be pink. You should be able to move the button. It should not be stuck to the patient's skin. You're not going to sit there and twirl and whirl it in a circle, but you should be able to move it. If there is secretions present or drainage, you want to note what it looks like. Over time, the balloon, it's actually filled with still water, and over time that can evaporate, or all the stuff is plastic and silicone, so it can become cracked, it can be defective, things like that. So you always want to check and make sure that the tube is flush with the skin, it's not popping out, and things like that. If you know any drainage coming around the side, if it's stuck to the skin, if it's excoriated, you don't want to be feeding or giving anything through the tube without calling someone to look at it. Generally, a wound care nurse handles a lot of tube replacement and malfunction and skin integrity issues with these. So when you're using the extension tubing, the biggest thing you're going to do is you're going to pop the top off the button, and you're going to align the dark black line on the button, which is over here on the left in the left purple circle, with the dark black line on the extension tubing, and you're going to turn it to lock in place. So you're going to line the two dark black lines up, you're going to push the extension tubing in while securing the button with your other hand and turn, and that's going to lock it into place. The same thing, when you want to remove it, you're going to turn it back and line them up while securing. You always want to secure anything that can come out, be it a gastrostomy tube, a tracheostomy tube, or anything else. You always want to have one hand on the tube itself and then one hand on the extension or the suction catheter or anything else, because you never want to remove them from the patient, obviously. You don't want that to be a complication of your day. And then on the end of this extension tubing, there's two little ports, so you can give meds and feeds and things like that through them. When giving medications through enteral tubes, there's several different types of syringes you can use depending on the port. And I make a point of this because some facilities only have oral syringes and Lurlock syringes available. So you want to make sure if there are oral syringes available, you want to use those with your enteral tubes. Because of the cost and availability and things like that, some facilities may choose only to have Lurlock syringes, which are traditionally what are also used for your IV and intravenous medication delivery. The bad thing about using a Lurlock syringe is that if one is left out, someone could inject whatever you've put in it into someone's IV, causing injury, death, things like that. So you always want to make sure all of your syringes are labeled before you walk into a room. You have a separate syringe for everything, and that all syringes are disposed of properly. Some want these disposed of in red bags, in sharps containers, and things like that because they are injectables. The good thing about the oral syringes is that they cannot be put into an IV port. If you'll note on the left, you have a darker color oral syringe. Those are very easy to see. That amber color, it's an oral syringe, very hard to confuse with a Lurlock syringe. The problem when you use those, sometimes it's hard to see the meniscus because it's very dark. So when you're checking, especially if someone pre-filled the syringe and sent it from pharmacy, you always want to make sure the amount that's supposed to be in there matches the actual volume that's in there. Versus on the right, with the oral syringes at the top. It's very easy to see the meniscus, and you can see how much medication is in there. However, it does look very similar to the Loralox syringe. So the American Society for Parenteral and Enteral Nutrition has set up some safety alerts in how to make everyone aware and deliver medications, feeds, and things like that through enteral tubes as safely as possible. So some of the big things we've highlighted here. You always want to flush these with water only, depending on the facility and agency policy. A lot of the times it is going to be sterile water. However, at home and with home use and families and things like that, sometimes tap water is used, and sometimes they may let them use that in the hospital. But you always want to know your agency policy, and water only, no saline. You want to flush before and after each med administered using the appropriate amount for the patient's age and condition. What does this mean? How much are we going to flush with? Typically, 1 to 2 mils for small tubes and 5 to 15 mils for large ones. We always want to consider the size of our kid. If we're working with an infant, we're obviously going to use less flush. If you have a child with some type of renal issues, so they have less clearance, a cardiac patient, so they're more at risk for CHF or cardiac volume overload, those patients are going to be on a fluid restriction. We don't want to use up all of their valuable fluid intake with water when they could be getting enteral feeds and things like that. So if you're going to flush in between, generally 1/2 ml to 1 ml in between meds is the recommended dose. In some facilities, if the medications are compatible, they will let you give all the meds together, 1 med at a time, followed by each med, and then just flush at the end and not in between. But that's something to depend on the condition of the patient and the facility. So always the smallest amount possible. When we're administering medications through the tube, we only want to give 1 medication at a time. We do not want to mix our drugs together. This is really important when drawing up liquid meds separately, but also when crushing pills and preparing them to give. You would only want to give, you don't want to crush all your pills together and draw up into 1 syringe if it's multiple meds. You want to do the pills for 1 dose med, pills for another dose med, and put in separately labeled syringes. If your tube becomes clogged, if it's defective and the end pops off and fluids leak out, you want to know if the patient actually lost a multivitamin, which is not a big deal, or if they lost their seizure med, which could become a problem an hour from now when your patient starts to have seizures on you. So you always want to give only 1 medication at a time. And then you don't want to add medication directly to the formula. This is important when working with enteral tubes or when feeding a patient orally through a bottle or a cup. You only want to use the smallest volume necessary to give that medication. So if we're having to mix a medication with something, about 2 to 3 mils, generally if it's, say you've got 5 pills or something like that, you may need to use more, or use warm water, not hot, to help dissolve it and crush fully, but you don't mix it in a large volume because you don't know how long it's going to take that patient to have all that formula, and so it's going to delay the release and delivery of that medication, and it's not going to be as effective. And then if you have patients who are on intermittent or continuous feeds, you also want to identify any meds that must be separated from the formula by greater than 30 minutes. And so you have to be really clear on when I start and finished my formula, or finished and gave my med before you can start your formula, etc. And then when you're looking at the rights, you want to make sure that you're only using oral or enteral syringes unless your facility only has the other available, and that you're only giving immediate release solid or oral liquid dosage forms. And what that means is if we've got something that is enteric coated, like ibuprofen and things like that, that are not meant to be crushed because they are not meant to dissolve until they are down in the stomach acid, or some of these extended release seizure meds, cardiac meds, and things like that, you're not going to crush those. In those situations, you would want to call your physician in the pharmacy and see if there's another dose or medication available that'd be just as effective, and things like that. You're not automatically going to open up and open up a capsule and sprinkle all your sprinkles or pills and things and try to dump that down a tube. Okay, so you only want to make sure that you're using immediate release solids or liquid dosage forms with that. And this is just kind of a summary and a review when you're looking at patients who are receiving enteral feeds, what the difference in a parenteral feed and an enteral feed is. So enteral nutrition can be whole food by mouth. They can have a nasogastric tube, an orogastric tube, a gastrostomy, jejunostomy, you know, things like that, nasoduodenal, nasojejunal. So you just always want to know where the tube is. Is it placed orally, nasally? Is it surgically placed percutaneously through the stomach? And where the feeds and meds are supposed to go. When you're looking at intravenous nutrition, that's going to be your TPN and your PPN. So that just kind of gives you an idea when you're assessing and reading your patient's chart where the medication should be given. Okay? Couple other tips for administering medications when you are giving capsules. Obviously, you can't flush the capsule through the tube without it clogging. And so as long as it's not sustained or extended release, then you are able to open and mix the sprinkles or the powder with water to give it in a tube. However, as we discussed before, you may need more water than usual to help mix and flush, especially if it's filled with sprinkles. You don't want to mix with anything other than water to give through the tube. However, if your patient can take meds orally as well, you may be able to sprinkle a small amount of food just onto a small spoon or bite of applesauce or pudding if they're able to swallow thickened foods. Okay. When you're looking at enteral feeds. So patients who would have enteral feeds would be those with some type of impaired ingestion, patients with celiac disease, patients with cardiac problems who need to gain weight before cardiac surgery. We already talked about cystic fibrosis a little bit with that. So some type that they would have impaired digestion, absorption, or metabolism issues requiring extra nutrition. So with this, when we're looking at these patients, they're going to be unable to eat generally greater than a week. And you know, if you have patients that have had short bowel surgery and things like that and they're adapting, if you have patients who have burns or something like that where they're needing like 2 times the caloric intake and 2 times the fluid intake, those are going to have increased needs that you're not going to be able to meet normally. So when we're doing feedings through enteral tubes, there's a couple different ways you can give it, and the physician may order it this way. It may be a preference, it may be a hospital policy, or it may be some way they do it at home. So you always want to know if they have a home plan of care that they're using in the hospital, or if the facility or physician has a certain preference. But you may give the feeds either via bolus, and so in that way, those would be intermittent feedings, and you generally have a big 60 ml cath tip syringe that you're going to hook into the end of the extension tubing. And you're just going to pour that in. So you're only going to pour in a small amount at a time to make sure that it's going down and that it's not clogged. The issue with that is you've got to direct pour it into the stomach. Any pressure or stuff like that can make it come back on you. So if the patient starts to cough or something like that, all of their gastric secretions and the formula you just put in there can come back up and you could be wearing it. So you always want to give, about 30 mils, fill the tube up halfway, let it go down, and then fill it up some more. And you want to make sure you're flushing that tubing fully after each use. The other way you can give it is through a feeding bag on a feeding pump. This can be used for continuous feeds or for intermittent feeds. Generally, your intermittent feeds run about an hour or two, depending on what's going on. And with that, you want to make sure you're changing the bag every 24 hours. So if you've got continuous feeds, you're going to still rinse it out each time your formula is replenished. If it is intermittent, you're going to flush the bag and tubing and rinse it out after each use, and that can just be done with tap water. So the biggest deal is the maximum hang time for formula is generally about 4 hours. So you never want to put more than 4 hours worth of formula into your feeding bag at any time, and then you want to rinse it out before adding more formula. and that's going to decrease the risk and buildup of contamination. And always check your agency policy on that, because they may, their maximum hang time may be less. You never want to carry feedings in and out of the patient's room if they are on isolation. So just something else to note, you would not take a can of feeding into an isolation patient's room, pour it into the bag, and then take the can back out and put it in a fridge to store for later. That would only be acceptable for a patient who is not on isolation, and then it would need to be labeled with the patient's name and medical record number and their information. Now, while there are many types of specimen collection, we're going to specifically talk about urine specimen collection in children, because there's a few variations on that, as well as tips and tricks to try to use when obtaining a specimen collection in a child. One of these things is going to be with a urine bag. Now, a urine bag is frequently used if you need to obtain a specimen collection for a urinalysis, so that would be a clean specimen collection, not sterile. And it would need to be on a child small enough that the urine bag itself and this little stick-on piece is going to further encompass the child's whole genitalia. So if it is a male child, it needs to fit around their whole scrotum and penis. If it is a female, it needs to fit around that whole urethral opening and be able to stick down well in order for it to be effective. The way you would use them is you'd either cut a small hole in the diaper or pull it out the side of the diaper so that you could see when it was full. The problem with this is children are mobile. It is very hard to get them to stick well. So you definitely could not use these for a sterile urine collection. Now, if you could get a male infant prepped well with your betadine or, CHG, whatever they have you prep with, prep it all well with, and get it stuck on really well, you might be able to obtain a pretty sterile specimen collection with a urine bag. Other than that, you're not going to be able to. So traditionally with a urine bag, you're going to need to only use that with a urinalysis. A trick you can use if you're using it for urinalysis is you can stick some cotton balls down into the bottom of the urine bag itself before you attach it, and that'll just keep that urine from running out as you try to get the urine out in a cup, or, it'll keep you from using it, and then you can actually squeeze your cotton balls into the cup. You want to make sure anytime you collect that you're watching it frequently. Because you need to send or refrigerate that urine analysis within 30 minutes, so it needs to go to the lab as soon as they void. If you do use cotton balls, you can either squeeze it into the cup, or you can place it and push the cotton balls down into a syringe, pop the end off, put the cotton balls down in it, and use the syringe flange to push down further and push that out into the cup. Another way you can do that is to put cotton balls in the patient's diaper itself and then turn around and squeeze the cotton balls into the specimen cup. And then if the child is old enough to understand, you may be able to get down with them and have them use a urine hat, collection container, or some type of new either a urine hat or a other type of collection container, and you're able to complete a clean catch with that patient. For some of your older patients, the same thing goes with the urine bag. If you can prep the area and keep it sterile, you may be able to do a sterile catch, but it's not going to be, there's still a chance that it could be contaminated. So the best way to obtain a sterile specimen collection is by catheterization. Okay, so if a 9-month-old patient needs a urine culture, you're going to need to use a sterile catheterization. And then another type of specimen collection and or urinary drainage receptacle we want to talk about is clean intermittent catheterization. And this is important to note the difference between sterile catheterization and clean catheterization. So clean catheterization is exactly like it sounds, it's clean. It is not sterile. You would not use this to obtain a sterile urine specimen for culture, and you would not routinely catheterize a normal healthy person with clean catheterization. This type of catheterization is going to be used with someone with like a spinal injury or some type of neuromuscular disorder like spina bifida. These patients do not, they have a neurogenic bladder. Their bladder, because they are so frequently catheterized, is not sterile anymore, and so they are able to use what's called clean intermittent catheterization, or CIC, to catheterize themselves. And it's a lot simpler than the whole sterile process, and you just want to be as clean as possible. The point with this is you need to check our facility's policy on it as well. Many patients may, with spina bifida or myelomeningocele, will use CIC at home, but when they come into the hospital, for example, at Children's, they want them to be cathed sterilely intermittently. Versus at Scottish Rite, we actually at Scottish Rite train patients to cath themselves, and so they will do CIC when they are in the hospital versus sterile. So you just want to always check your agency policy on that as well. They may cath urethral, or they may cath through an appendicovesicostomy. And what that is an augmentation where they have augmented a piece of bowel with through the appendix to the bladder, and they bring it out right around their belly button, and they are able to stick the catheter in right around their belly button. It goes down their bladder, and they're able to catheterize themselves. The nice thing about that is that they don't have to have their pants off to cath urethral, so they can pretty much cath. If they're in a wheelchair, they can cath from a wheelchair. They don't have to be transported. They can do it themselves, especially if they have musculoskeletal disorders that necessitate their arms are either shorter or they're not able to move and reach as well. And so that's the nice thing about the appendicovesicostomy. So what I'm going to show you real quick is a video of an adult patient with an appendicovesicostomy cath herself. And one of the versions of it is called a mitrophanol, and that's what you're going to hear her describe it, but it's pretty much an appendicovesicostomy is what she's describing. So we're going to pull up this video real quick for you to see. And one thing to note, if you are actually using CIC to cath the patient, obviously you would be wearing gloves.
initially I get quite a lot of mucus build-up. That's where I felt this bladder. I had to wash out about once a week. Which I didn't have to do anything to look now. I catheterize about 4 to 6 hours a day, depending on how much I'm doing or depending on how full I get throughout the day. I'm supposed to drink about 2 liters a day. Fluids. It's generally recommended for people for mitral users to look in a catheter, say once a week overnight. But generally, you should be able to go on that going once you use it. I use that for my drink for about 8 o'clock at night and then let it sort of filter through before I want to go to bed. And then I should be all night until the morning. If I have a problem, I will contact my specialist nurses straight away. And if it's out of hours, then I have to leave the emergency department. Okay, so we're finished. We'll just tap that. Slides out quite easily.
Okay, so now we're going to go ahead and move on and talk about intravenous therapy and medication administration. So first off, you may see patients with peripheral intravenous catheters, and you may see patients with central venous catheters in the inpatient hospital setting. And so this is just what I'm wanting you to look at is assessment of the IV site with this. So with children, we do not generally rotate the IV site every 72 hours. If they're going to be hospitalized for 5 to 7 days, they're probably going to have a peripheral IV. They're probably not going to take it out as long as there's not a problem. So it's very, very, very important to note and assess what the site looks like. Children have small veins. They're more fragile than adults. We're generally going to use anywhere from 20 to 25 gauge needles. And these are going to be used for that short-term therapy. Okay. Most facilities now have gone to saline locking versus heparin locking, so they will flush these with saline when they're done and just clamp off the end. So they would be what's called saline locked when not in use. Okay, so if you notice on picture 1, you have that insertion site, and you can see that catheter right at the tip. They've got a couple pieces of tape over the skin, and then they've got a tegaderm or an occlusive transparent dressing where you can still see the actual insertion site, and you can look for swelling. So when assessing your IV sites, you always want to compare the extremity with the IV site to the other extremity and look for erythema, you're looking for edema, so any redness, swelling, and you're looking for skin irritation, rash, things like that, pain, and what it looks like. You don't want to secure it with any more than a piece or 2 of tape. You always want to be able to see that site, but you also want to make sure that any extension tubing or anything coming off that site is secure as well off the main catheter, so that if they don't catch it on anything, it doesn't take the IV all the way out, because the last thing we like to do in children is unnecessary procedures just to restart an IV, because it's another painful, invasive procedure. Okay. A lot of the times with children who are dehydrated and things like that, if they can drink, we are going to let them drink, and we're going to let them do oral rehydration versus IV rehydration therapy, because it's an invasive procedure we like to try to avoid. So the best way to secure the peripheral IV in a child is, like we said, get it, once it's placed, secure the actual catheter itself, as you see right there. On the catheter is the tape. Then you have that extension tubing hooked in. It is hooked up with an occlusive transparent dressing where you can see the insertion site. On top of that over here, you see there is a handboard, so they can have a handboard, an arm board, or something like that that's on. And then that you have an IV house. And these are actually, they were made by this company, and they're called IV houses, and frequently they have a little dog on them, and it's a little dog in a dog house who's sleeping, and her name is Ivy, I-V-Y. So we've got Ivy the dog house on the IV. And what they do is they tell the small kids, they put the sticker on there and tell them that the puppy's sleeping and to leave the puppy alone. So it actually is a pretty good deterrent, most of the time. So you still, this is one piece of tape over this, you can still move that tape on and off and flip that IV house up and down if you need to further assess the site better. So we don't want any type of non-transparent Coban, large amounts of tapes, anything where you would not be able to constantly see the site, no ACE wrap, nothing that would cause any further damage or cause a buildup of fluid. So then we have central venous access devices, and so these are generally indicated when the child lacks some type of suitable peripheral access. They may require IV fluids or meds for longer than 3 to 5 days, or they have to have specific treatments, such as administration of highly concentrated solutions like TPN or total parenteral nutrition, or other irritating drugs that require that rapid dilution. A good example of that is vancomycin, because it's a vesicant and can really cause irritation and infiltration. With this, it's important to look at, if you're looking at how your PICC line is placed, how many lumens it has, what does the site look at, and things like that. So just walking through the pictures when we're looking at this, this is a single lumen peripherally inserted central catheter or PICC line into the right arm. As you can see right here, going into picture 2, you'll see this device that they're placing, and then you'll see that it's placed here. This is what's called a stat lock, and it slides underneath the wings and has these 2 little prongs that you can see here. These blue prongs actually fit into the holes on each of the wings, and then there's a piece that folds over and it actually locks it into place. The nice thing about these is that then your PICC line does not have to be sutured in. If it becomes necessary to change the dressing and to clean around the site, it is easy to do so. If the catheter becomes dislodged or needs to be pulled back a little, or something like that, all you have to do is take off the stat lock and put a new one on. So with this, you can see that we've got the device itself, we've got the stat lock that's been secured, and then they have, on top of that, they've secured the underneath, so there's nothing poking into the skin over here with a little 2x2. This is, on top of it is a bio patch, and this is like an antibiotic patch that helps reduce contamination, and that has been placed on the top of the site around the PICC line and covered with an occlusive dressing. And so this looks what it looks like after the bio patch is in place, and you should be able to see the bio patch. If they've got a new PICC line placed, you may see a few little spots of blood or some drainage on it, but note that if that bio patch is totally saturated with drainage or blood, it is not effective anymore, and the IV team or the PICC line or central line team needs to come look at it, and it probably needs to be changed. Depending on the facility you're at, you may have, the nurses may change central line dressings at the bedside, or they may have an IV team that does that. So that's included its date and time when the dressing was changed. And then because of the tubing and anything else, we definitely don't want to pull out any IV, but definitely not a central line. And so you see there's just that cotton mesh stockinette netting that can be pulled over their arm that can be moved to assess the site as needed. So So the big thing to note with this PICC line, the tubing or the lumen of the PICC line tubing is smaller in diameter than that of other traditional central lines. Increased resistance with the PICC line can collapse the tubing. So if you're using a 1 or a 3 millimeter diameter syringe, it can actually, if you're drawing back, trying to draw back blood or push fluids through, it can actually collapse your tubing. And so you always want to use syringes that are at least the diameter of a 5 to 10 mil syringe when flushing or administering meds. So when we're working with infants and young children, they're at a much increased risk of fluid volume overload compared with adults. And so we talked about this a little bit with our enteral feeds. When you're looking at those insertion sites, we've got the small veins and things like that. So malfunction with that IV insertion sites, infiltration, pulling it out that can cause, or pulling it back too far, can cause a lot more damage and injury in a child more quickly than it would in an adult. So we have to really monitor IV fluids carefully. And so one of the best ways to ensure accurate fluid administration, you can use infusion control devices such as infusion control pumps, syringe pumps, and volume control sets to help deliver your IV fluids and medications. And so the primary method for IV medication in children is the syringe pump. And it allows you to deliver a highly precise rate of medication at a controlled rate of infusion that's more controlled than IV push. So you can use anything like up to like 1 to 3 mils all the way up to a 60 mil syringe will fit in these. Okay. The best thing is, so when we're looking at direct IV push in kids, we're typically using that, reserving it for emergency situations with kids. If they're coding, if you've got a seizure, kid with a prolonged seizure that you need therapeutic med levels to be backed up quickly to get the desired effect in place and to stop seizures, that's one of the only ways that we would use IV push in kids. The rest of the time we're going to be using a syringe pump. So what you're seeing right here is you're seeing one of the syringe pumps that's primarily used. Those are the ones that you're going to work with in the lab at TWU, and currently they're the ones that Medical City Children's has. These are Medfusion pumps. And as you can see, it'll hold, there's different brands of syringes, but it has the syringe in it right here, and it's going to lock on to the body of the syringe, and then you'll have the flange here, and then you'll have the little tip of the flange, and this will capture this. And so this is being held, the body of the syringe is being held secure, and then this piece right here is the driving force pushing, just like you would push it at a controlled rate through the tubing. At Children's, they have this multi-pieced contraption that they actually have what is called a pump brain. They use Alaris pumps. This is a pump brain, so it's like your computer CPU unit, and then this would be like your other pieces that are hooked up to it. So this itself will not do anything without these attached, and vice versa. So this is a syringe pump, and this is where it would secure the syringe, and this is where the flange would fit and push it down, and then this is where you'd have your primary tubing flowing through on this side. The reason I mention as far as this pump brain piece is many of our students at Children's are on what is a neurosurge unit, and a lot of these patients have shunts, and they may occasionally tap or pump their shunts for extra cerebral spinal fluid, and that's something different. And so on your equipment list, on your patient's Cardex, you will see under equipment list, you'll see pump brain, pump primary, pump syringe. That is what that pump brain is talking about. That is not talking about pumping a shunt. So just something to note. At Scottish Rite, they have these pumps, and the same thing, this is the syringe is secured in here, and it's pushed in there. The nice thing about syringe pumps, they will use pretty much any syringe brand or type from 1 to 3 mils up to 60 mil syringes, and they all use the same exact tubing. And the tubing that they use is microbore tubing. So the biggest thing that you have to do there is note the agency policy on how frequently you will want to change that tubing. Okay? Okay, so a couple things to think about when administering medications through a peripheral IV catheter or a centrally inserted IV catheter. And so I'm going to go back here just because we have a good picture of this cap and the port of the IV. And so how are we going to prepare this port or the hub of an IV catheter or that primary tubing prior to access? So you always want to make sure that you're scrubbing the hub. So remember that, scrub the hub. Always look at your agency, policy, and clinical practice, but we're going to say a minimum of 20 seconds. Generally, you're going to use an alcohol wipe or a CHG wipe. Some facilities now have CHG caps, or what's called a Curos, C-U-R-O-S cap, that's going to pop on the end when not in use, but you're still always going to scrub the hub. When administering your IV medications, you're going to always draw back, flush back with saline first. You're going to administer your antibiotic or your other medication. You're going to flush with saline again. So you're going to remember that SAS, S-A-S, mnemonic. If you're flushing with heparin as well, that's where you're going to use SASH or S-A-S-H. So you'd always flush with saline, give your antibiotic or other medication, flush with saline, and then heparin if you are giving heparin. Okay. How long are we going to infuse our medications over in minutes? Just a hint, the doctor does not order this. So you always want to know your resources and your references. So you can look up your medication in a drug reference resource. You're going to look that up either online or using a hard copy of a drug reference book, and you're looking specifically for the infusion rate or time. Okay, so if it tells you to infuse it over 30 minutes and you have 50 mils of medication, you're going to infuse it over 30 minutes, so you're going to set the pump at 100 mils an hour. If it just wants an infusion, that'd be your infusion rate. If it just wants an infusion time to be input, then you would just input the 30 minutes. Okay, so that's pretty much it for our skills information for today. So your job is to answer the prep questions and to take the self-test before coming to Skills Lab Day and practicing with hands-on practice. Thank you.